Hello, everyone. Welcome to the 119th Stanford MedAI Group Exchange session. This week, we have with us Aisha Urooj from Mayo Clinic, Arizona, here to talk about her work on developing a framework for exposing vulnerabilities in clinical large language models. No, I think it's an AI-driven advancements in mammogram analysis. Aisha is a research fellow at Mayo Clinic, Arizona. She received a PhD from the Center for Research in Computer Vision at the University of Central Florida, where she was advised by Dr. Mubarak Shah and Dr. Niels Da Vitoria Lobo. She also worked at MIT-IBM Watson AI lab as research scientist intern in the summers 2020 to 2021. Her research interests include multimodal understanding tasks involving language and vision. Her recent work is focused on learning joint representations from imaging and clinical reports and developing efficient AI systems to assist radiologists in their diagnosis. Aisha, thank you so much for joining us today. Before we start, do you have any preferences on how you would like to take the questions?
No, I think I can take the questions as they come.
Awesome. So let's try to make this session as interactive as possible. And without further ado, let me hand it over to Aisha.
Okay, thank you so much, Aisha. So hello, everyone. I'm Aisha, and today I will be talking about my work done in screening mammogram analysis and doing this AI-driven advancements for a couple of use cases in screening mammograms. Okay, so breast cancer is one of the most common cancer which occurs in women, and it is a second leading cause of cancer death in the US. Globally, in 2022, according to a WHO report, there were 670,000 deaths occurred in the world. And however, despite being a most common cancer and being the leading cause of cancer death in women, if we detect this cancer early, the survival rate for 5 years is close to 100%. But if it gets undetected and we detect it really late, when it is metastatic and has spread to other parts of the body, the survival rate drops to 22%. So early detection is the key here for breast cancer survival. On the other hand, there are around 41 million when we are doing the screening mammogram. So to detect this breast cancer early, one approach is to do screening mammograms for women over 40 plus of age, and so that we can detect it early and do the cure as needed. So this leads us to a very large number of mammogram exams done. Just one of the stats is that in 2024, for more than 41 million annual exams were done. So this gives us a very huge number of mammograms, which the radiologists are needed to screen and read. On the other hand, there is a widening gap of radiologists which are going to read these mammograms. So over the years, we can see under this gap between the need or the requirement of the number of radiologists we have as the actual radiologist to read this mammogram is widening. So there will be soon there will be a chance that the resident which are trained for breast imaging, they will be eventually reading these screening mammograms and examining them. So for that purpose, we need an adequate training of these residents. A standard approach according to American Cancer Screening Academy, their residents are required to do a 12 weeks training where they are required to annotate 300 breast imaging exams, including mammograms, ultrasounds, and MRI. So, however, to train these residents, a usual approach is to handpick the exams, which is very time consuming. If you have, let's say, a million of exams, it is very time consuming, it is challenging, and it may also introduce a sampling bias. And we might not be able to get adequate number of distributions or case sets to train these residents. So the use case arise here is that we need to automate this relevant training case selection, which means we want to automate a system, a retrieval system where we are able to pick examples or the relevant cases based on the queries. This led to our work for building unique case set for screening mammograms for resident training. And to do so, we went for visual language models, which knowledge grounded adaptation to medical domain. This work was done in collaboration with UW Health Medicine. So now we know that, okay, we have a very huge number of mammograms. We want to come up with a system where we give a query and we are able to retrieve the relevant cases. So for that purpose, we have, let's say, a given bilateral mammogram image and the corresponding radiology report. We want to learn a joint embedding, which once we have trained this joint embedding in the form of a visual language model, this will be our retrieval framework. So now if we give a query image or text report, we want to fetch the relevant cases from the joint embedding space. However, it is challenging. It has its own challenges. First challenge is that the VLMs, visual language models, are very successful in natural domain, where they are trained on natural images and natural text, which is very different from medical data. In natural images, there will be often 3-channel images, but for medical image domain, there can be 2D, 3D, even 4D if taken exams are over the time dimension. Also, the images look very different from natural images. In natural image, a same object may appear like this stays semantically same, but the appearance may be different, which makes it a different pair, different image.
Aisha,
On the other hand,
Aisha, I have a question over here.
Hmm.
Yeah. So what are natural images? Could you explain it once more? I'm really sorry. I couldn't understand what natural,
Okay.
how natural images are different from medical images.
Okay, so natural image is just any other image we take in the real world. Let's say a cat, an image of a cat,
Okay.
or an image of a dog, or any scene.
Okay. Okay. Got it.
So whenever, even for a given scene, when we take an image differently, it will be appearing, the image will be appearing different based on the transformation which may occur due to the scale or, let's say, view from which we are taking that image, and so on. And based on whatever image is appearing or whatever the combination of objects is appearing in an image, the caption will also be different, which we are saying natural text. On the other hand, for medical images, like I said, that first is the dimension can be different. The appearance could be very different because most of the time the exams, they look very similar, but we are looking for abnormalities in those exams. So the most content is similar, look very similar, they are grayscale. But excuse me, the lesion could be very minute and it may pose different challenges. Another thing is that when given the radiology reports, they have very minimal syntactic differences. Most of the terms are standard, only based on the findings will be different. Also, particularly in the case of skinning mammograms, the dense tissue may also include abnormal image findings, which makes it very challenging. Another challenge for skinning mammograms is that there is a huge class imbalance between normal cases and abnormal cases, because screening mammograms are done as a prevention measure and they are being done annually. So most of the time, the patient will not have breast cancer. So this gives us, let's say, 90% of the cases are negative in screening mammograms and only 10% will have some finding.
I should have a quick question here. If you just that point A, so it's minimal syntactic difference between reports. So it's like you have these mammograms, but like, so does it mean like two mammograms can have the same report? Because the reporting is very structured, but then the images look very different.
Right.
Okay.
And even if there is some finding which is different, some of the sentences, if we are taking the whole text, most of the sentences will be very similar. So the embedding, in the embedding space, the text will appear very same.
Okay, thank you.
So to learn a joint embedding space, usual approach is to use contrastive learning. And the key idea of contrastive learning is that we want to group similar examples. We want to have them very close to each other in the representation space. And the different examples should be further apart. in the feature dimension. So for instance, here we had given two modalities for modality A and B. A typical approach is that we want to bring the positive examples closer to each other and the negative examples should be pushed apart. However, the existing examples existing approaches, let's say mixed margin and clip, they does not take into account the possibility of false negative. Because the contrasted learning, first thing, okay, it's when we are comparing and contrasting, we need to find negative examples. And the usual approach to find these negative examples are that we basically sample a hard negative example within a mini batch. For natural images, it works, but it won't work for our case because there is a huge class imbalance. So when we are sampling a mini batch, there is a chance that the example we are sampling, randomly sampling as a negative, belongs to the same class or is very similar, and we are trying to push them apart. Then, and also again, the same point that the reports are semi-structured, which gives us very similar embeddings for very different findings. So to address these challenges, we proposed a solution to adapt these visual language models by using an efficient sampling, mini batch sampling approach. And it basically ensures two things. First, we want to address this problem of true negative. We want to make sure that within a mini batch, whenever we are sampling a negative example, it should be a true negative example. And then another case is that in medical domain, because we have this huge class imbalance, we want to make sure that the rare cases are also equally represented within a mini batch. So we propose a three-step solution for this mini batch sampling. First step is knowledge extraction. So we have a standard BIRETS vocabulary with 54 image descriptors, and using that vocabulary, we extracted different features out of the radiology reports, such as breast composition, calcifications, asymmetry, mass, and surgical changes. So for example, so to extract this knowledge, for example, we have this radiology report, and we detect these key concepts based on the defined vocabulary we have, which comes from BIRETS.
Aisha, we have a question from the audience. So he's asking, how different is it from stratified sampling? How is your sampling different from stratified sampling?
It is kind of like the approach. The idea is similar. The difference is that we adapted it specifically for the medical domain. So the knowledge extraction is also based on the medical vocabulary. And one more thing is that we are taking into account the rare groups. So that has not been done previously. And I will go into the how we are catering the rare groups in the next slide.
Thank you.
Hopefully that will make it clear.
Yeah, hope that answers your question.
Okay, so first thing was that we wanted to extract these key concepts, and then we say that the combination of these key concepts make it a unique group or a unique class.
Aisha, a question. So how were you extracting these key concepts? Did you use some algorithm like a topic modeling or LSA, LDA or something like that?
No, we tried those algorithms. Those were not working in practice, in practice. So we had to extract these key concepts separately. Let's say we extracted tissue density separately, and then we extracted all the key features were extracted separately, and then based on the existence of these key concepts, they were grouped.
And like what algorithm did you use? You extracted them manually then, or like what algorithm did you use?
Did a key concept search.
Oh, key concept search. Okay.
Yeah,
Thank
search.
you.
Okay. So once we have this, we have extracted this knowledge and we have formed this group. Now we will be doing this knowledge grounded grouping, where the concept is that any unique combination is actually a group. However, the group or the combination of these key concepts is permutation invariant. So that means it doesn't matter in which order these key concepts has appeared, as long as the key concepts found in a report are same, those two reports belong to the same group. So once we have formed this unique grouping based on the existence of certain findings within a text report, we can now use it for mini batch sampling and using it to pre-train our visual language model. Here I'm showing top 20 groups in the internal test set. We could see that the top 3 groups are coming just from the tissue density. That means these reports had no finding in them, which means they were most of they were coming from the patients which had no any like lesion in the exam, and only the tissue density is reported, which is expected. Then the step 3 is selective sampling. So once we have formed these groups, now we want to sample a mini batch, ensuring those two properties. One of them was we want to make sure that the true negatives are always sampled within a mini batch. And second was we want to make sure that rare groups are equally represented in the batch. So we formed, so based on, once we have this set of groups, now based on the frequency of any group occurring within a data set, we form them into frequent groups and rare groups. And that boundary between the frequent groups and rare groups, it depends on the data distribution, and it is chosen empirically. So once we have formed these groups, so to make sure that the hard negatives are coming from like the two like negative sampled from within a mini batch is always a true negative. We are sampling unique samples. So each group will have only one sample, let's say, within a mini batch. So this makes sure that all examples within a mini batch are coming from different classes or different groups. So whenever I'm sampling a negative within a mini batch, it will always be a true negative. For the rare groups, we formed a boundary, and then we say, okay, let's say in any mini batch, we will be always randomly sampling 3 rare groups, 3 examples from rare groups. So that in that way, we are making sure that the examples are, the rare groups cases are always represented, because as I mentioned, that we have a very long distribution. So there will be many cases which will have only 2, 3 examples or even 1 example in them. So this is our workflow. So first we given the image text report dataset. Using the reports, we did this knowledge extraction. And then we use this knowledge extraction, we formed groups. And using these groups, we do the selective sampling like I explained before. And then given this mini batch, we pre-train our visual language model. Now this visual language model could be fine-tuned for the downstream task, but we also evaluated it in 2 setups. First is zero shot, where you take the out-of-domain data and you use this pre-trained backbone to do the retrieval on this unseen data set. For few shot learning setup, we selected cases up to K from the in-domain data set that will form our support set. And then we use the same proposed selective sampling to pre-train our network or fine-tune our network using the few shot learning approach. For evaluation, we did internal validation as well as external validation. So for internal data set, we used IRB approved URW medicine data set from 46,000 patients. And we considered 72,000 bilateral screening mammograms between January 2016 to 2018. The images we took were MLOview images. To effectively train our data set, we separated 1,000 images for validation and 1,000 for test set, and the training set was composed of 70,000 image report pairs. We also did external validation on Mayo Biobank dataset, which had around 8,000 training image report pairs and 1,015 used for external validation. So we did not use the training set. It's just only use the test set for external data set for this validation. In terms of data pre-processing, so to pre-process these images, we first cropped the breast tissue area from each MLO view. And once we have cropped the breast tissue area, we stitched both views together. And then to make sure that the aspect ratio is maintained, we zero padded these stitched images to make them a square image. And then we resize this to 512 by 512. For the text pre-processing, the reports were first clean and lowercase. We removed any negation sentences before extracting these findings. For instance, there's no significant masses calcification. So if we were doing simple text search based on, it will always detect this calcification based on this sentence, but this is actually a negation sentence. We also removed redundant sentences from these reports. So in terms of retrieve performance, the evaluation metric which was considered was recall at K, where we want to see whether a relevant case was picked up in top K position or not. and a relevant case is considered, like it is considered a hit when a case from the same group is picked within the top Q position. So we are not looking for an exact image report pair match. We are looking that as long as any finding from the same group comes in the top Q position, it is considered a hit. So we took two baselines. First is, which were two visual language models. One of them was out of domain visual language model, which is LBEF. It was originally proposed for natural images. And we also considered MATCLIP, which is in domain baseline for us. And it was originally trained on Chexpert dataset. So for image to report retrieval on internal test set, we compare in terms of recall at 1, 5, and 10. LBEF gave us like huge performance gain when we were doing this selective sampling. Okay, one thing is that LBEF retrieval model was pre-trained on our data set, on the UW Medicine data set, and then we find it on retrieval task based on their proposed pipeline. But we are not doing any adaptation, like I mentioned, the mini batch sampling. We just trained their system as they proposed. And then our baseline was where we were using the selective sampling to form mini batches before training the model. For MATCLIP, we are seeing comparable results for image to report. However, in terms of report to image retrieval, we are given a report, we wanted to pick an image from the same group. We see that our model, both MATCLIP and LBEF SS, was giving us huge performance gain using this selective sampling. On external data test set, however, we find that image to report, we did not see any gain here, but in terms of report to image, our model was beneficial, particularly for LBEF SS. In terms of decollect one, we saw a huge improvement compared to the baseline. And same goes for MATCLIP SS. We were consistently seeing an improvement on external test set. In the form of zero shot and few shot performance evaluation, again, we are comparing for image to report and report to image retrieval. For zero shot evaluation, we compared with three baselines. First was off-the-shelf MATCLIP model, and then we also compared with off-the-shelf LBEF model, which was pre-trained on MS-CoCo or Flickr 30K. And we see the retrieval performance of our LBEF retrieval model, which was trained with selective sampling. And for few shot, we considered K equals to 10. That means that we consider cases up to 10. If a group has less than cases or less than 10 cases, all of the samples are considered. If a group has more than 10 cases, we will only consider 10 cases over there. On internal test set, we find that for image to report, few shot actually gave us better performance compared to the baseline model, which is MATCLIP and LBEF. And for report to image, we see that it is giving us better performance. MATCLIP is giving us a 10% improvement, let's say on recall at 10. However, here for LBEF, the results were comparable or slightly, let's say we have improvement in recall at 5, but there is a slight drop in performance for recall at 10. On external test set evaluation, when we were testing it externally on zero shot, our model was significantly outperforming the baselines. However, it is expected because of the pre-training we performed. For image to report and report to image, when we are looking at, for image to report, let's say, for MATCLIP and LBEF SS, we saw a huge improvement in recall at 1 for LBEF SS. For image to report, MATCLIP was giving us, I would say, like mixed results. For report to image, however, we find that both MATCLIP and LBEF was giving us improvement in terms of recall at 1 and recall at 5, particularly in recall at 5, actually. But overall, we found that for our use case, where we want to not only pick the common cases, we also want to pick the fine-grained, what should I say, like the cases based on the fine-grained examples. We looked at the overall benefit, and selective sampling was more beneficial compared to the baseline models. We also considered various design choices. There are many design choices for doing the selective sampling. First is ratio, like how many number of frequent groups and rare groups within a mini batch we want to keep. So let's say for a mini batch of 8, if we keep 3 examples from rare groups or compared to equal number of examples coming from frequent and rare groups, we found that, so this R is basically how many examples from rare groups we want to keep within a mini batch. And we find that the keeping between 38 to 50% examples give us better performance. Give me a moment. Right. And we also wanted to see that when we are doing this mini batch sampling, we are randomly picking examples from frequent groups, and we are also randomly picking examples from rare groups, but a boundary stays the same. So we wanted to see what if we again shuffle the examples within a mini batch, and we find strange, like we were hoping that maybe batch shuffling should help, but if we don't shuffle the batch, then it gives us better performance. Another thing was the boundary, like how many groups we want to consider as frequent groups and how many groups we want to consider as rare groups. So that also needs to be recalibrated if the data distribution changes. For example, based on the full data set, we found that, let's say, top 10 groups or top 20 groups should be frequent groups. But when we were doing few shot, this experiment is done based on the few shot training. So when we were doing few shot learning, if we select up to 10 samples, the data distribution changes. So now we have to recalibrate the number of frequent groups, and we find that recalibrating is helpful. So basically, if we want to learn fine-grained representations in medical domain, that a careful adaptation of these visual language models is beneficial. Here are some qualitative examples. So let's say for a given query, irregularly shaped mass, we want to retrieve relevant image report pairs. We show examples of coming retrieved from LBEF and compared to LBEF selective sampling. Again, we are showing top 3 examples as top 1, let's say 2 and 3. For LBEF, the text is very small, but I could tell you that the top 3 examples, these are all coming from no finding cases. LBEF SS, however, was giving us reports with some finding, with the correct report coming as the second position, which says irregularly shaped mass. The first example, it's said mass, but it was not the mass which we were looking for. And then there is another query. The query was coarse heterogeneous calcifications. For LBEF, the LBEF was able to detect calcification in each of these reports, but it was not able to retrieve this specific type of calcification, which is coarse. And here LBEF SS, it was also able to retrieve the cases with calcifications, with the correct case with coarse calcifications coming at the second place. So these are some examples where our approach was beneficial. So the takeaway from this work is that if we want to learn meaningful representations from medical data, we need to go for non-trivial ways to adapt this contrastive blending loss for training our models. Future directions for this work is to apply this pre-trained embedding to downstream tasks such as tissue density estimation and varied prediction within screening mammograms, which can be a huge benefit because it will reduce the workload of radiologists, and they may look for cases where they need additional information or additional exams based on the BIRAT score. Also, we found that our approach performs better with a smaller batch size because there is a dependency between the batch size and the number of groups we want to frequent and rare groups we are considering. So we need to do intelligent sampling to balance the groups for larger batch sizes, and that is something which is a part of future work. Then the second, okay, are there any questions so far?
In the exam, this is very interesting. In the example you showed where the irregular mass, this one, this one, it's how come, like when I think of mammography, like the two main signs they look for is mass versus calcification. So like those are the two big concepts, right? But here you're asking for a mass, but it gets a benign calcification. Do you have like why it's making that type of mistake?
It
I'm just curious here, just to,
yeah,
yeah.
it is actually okay. It is actually very difficult. It is a very hard task to learn these fine-grained representations. So
Mm,
classification is a common case. Mass is again a common case, but how it has learned it, I
okay.
think depending on how we have trained and we're focusing on fine-grained classification, I think to me it is hard to determine.
Good. Thank you.
And one more thing, I think, thanks for pointing me to this example. So the cases were marked as relevant or irrelevant by a radiologist who was looking at these retrieval results and then find which cases are relevant and which cases are not relevant.
Good.
Any other questions? Okay, then I will move on to the second case of second work, where we want to segment and measure breast arterial calcifications in screening mammograms. And this work was done in collaboration with Emory University. So the task here is, now we have these screening mammograms and the breast arterial calcification, which is basically a calcium deposited in the arteries of breast, they can be an indicator of cardiovascular diseases in women. So now, because we have these screening mammograms already available and these calcifications can be readily viewed by radiologists, if we are able to measure this BAC, then we could help. It is a non-invasive approach to assess the risk of cardiovascular diseases in women. Let's say if a woman has a high amount of BAC in the screening exam, they might be sent to for more cardiovascular disease-related exams. However, but this is very challenging task because of the few factors. One is the variation of breast tissue density. So based on the tissue density appearance, it may be hard to detect this calcium deposition. And it is also hard to annotate as well. Like if we want to detect this BAC in screening mammograms, we need ground truth data. And the ground truth data is hard to annotate because it has complex structure and the presence of BAC is very microscopic. Also, there is an extreme class imbalance between true BAC pixels and no BAC pixels. So I will be actually briefly diving into this work. But one thing which we proposed here is we already had, let's say, a segmentation model, which was unit-based segmentation model. And it was trained using image patches. And so the patch-based training was done for two purposes. First, because we have very like the presence of BAC is microscopic, but the image is huge. We don't want to lose the resolution. If we reduce the image size, resize it, we will lose that information which we want to detect. So a patch-based training helps us in training effectively for this BAC segmentation task. What we did it that we added another task to the segmentation model, which is patch position in the original image. So we are given a patch. We not only want to detect the output mask, if depending if it has some BAC presence or not, but we also want to predict what was the position of this patch within the whole full exam. And that is based on the observation that most of the time, a model which does not have this information of the image, with the positional information of the patch, it makes mistakes at the bottom side of the breast tissue and often confusing breast folds with BAC. So this model was optimized. So it is a two-head BAC segmentation model. First is one loss is segmentation loss, and then the patch prediction loss is another task, and the weighted sum is considered as a total loss to train this model. But training this model has a couple of challenges other than the class imbalance as well. One thing is that the radiologists, they only give us the splines, so we do not know the actual width of the labels. So we had to apply width to these annotations, which were actually just the points on mammogram. So this actually makes the segmentation mask, which we are going to use as ground truth, a bit noisy. Also, another challenge was that the radiologists, they only annotated heavy depositions so the labels are noisy and incomplete to train this model. I will show just briefly some results. So we considered 398 screening mammograms from MIT-IBM approved dataset with a 50-50 ratio between subjects which had some BSc and subjects which do not have any BSc, and 3 expert radiologists annotated heavy BSc only. We took this 80% of the data was used for training purposes, and 10% was used for validation, as well as, and 10% was used for testing this model.
Aisha, I have a question here. So in that data set with the 50-50 with BSc and no BSc, amongst the reports or amongst the mammograms which had the BSc, radiologists annotated a part which had heavy BSc, right? Like, okay. Like heavy BSc, like mammograms showing heavy BSc are a subset of the mammograms with BSc, right?
Right.
Okay. Thank you.
Okay, so we compare with 2 baseline. First was deep lab, and then this SCUNet. SCUNet is a dedicated, I would say, BSc segmentation model, which is a very lightweight model. And when we added an auxiliary task, that auxiliary task of patch prediction to this baseline model, and we found that it was able, adding this patch prediction task was able to give us comparable performance to deep lab model, which was in terms of learning parameters, it was very like magnitude of order of magnitude larger in size. We compared in terms of recall precision and F score, and DICE score. So F score and DICE score are the 2 measures on which we are focused at, and we were able to see that the DICE score was better than both baselines. In terms of qualitative results, so these results are from our internal test set on every data set. So we have this, given this screening image, this is the ground truth, and the last column is the predicted heat map, and we were able to see that even the ground truth was incomplete, the model is able to detect the BSc in rest of the breast as well. And same is the case with the bottom example, that the model was able to detect this BSc at the top of the image, breast image, and despite having the ground truth which was incomplete. So we also validated our model on external dataset. For that purpose, we took Mayo Clinic dataset. We took screening mammograms from more than 7,000 subjects, which were captured from different sites with no prior history of any cardiovascular diseases. So this dataset has no annotation. So we do not have a mechanism to evaluate the performance of our model based on the DICE score or Jaccard score or recurrent precision of pixel detected for SBSE. So how we are evaluating our model is that we are measuring a BSE score in terms of the detected BSE normalized with respect to the breast tissue area. So we have a screening mammogram, we detect the BSE pixels in it, and then we compute a BSE score based on what pixels were detected as BSE, and it was normalized with respect to breast tissue area. So now we have this BSE scores for each exam. We cannot compare it with any ground truth because we do not have ground truth, but we could evaluate it based on the survival probability analysis. For that, we use this Kaplan-Meier survival curve, which basically tells us that within a given time period, if given a defined starting point and a certain event, what was the survival rate for a subject. So here, the starting point for us was the date of screening exam, and the event occurs when any cardiovascular CVD event happened in future. So we took data for over the 15 years. We grouped these BSE scores in 3 categories based on low BSE, mid BSE, and high BSE. And we found that, and we did this study on left MLO and right MLO separately. And we find that the survival rate curves tells us that the BSE score was meaningful, and it shows a high correlation between the survival rate in terms of, let's say, for mid-BSc and right BSc, over 10 years, they are kind of overlapping, but after 10 years, the high BSc, the survival rate for patients with high BSc drops significantly down, less than 70%. And same is the case with for right MLO as well. So in this example, like just looking at the survival probability, it tells us that the BSc scores were meaningful and they were showing a correlation between the CVD events and the presence of BSc. These are some qualitative results on Mayo external data. So we are showing predicted heat map and the binary mask for different varying tissue densities here for mid BSc and high BSc cases. So the bottom row is the case with high BSc, and the top row are the examples for mid BSc cases. We could see, let's say in this example, it is very hard to see BSc, but the model was able to predict it correctly. So to conclude it, we actually in this work, we proposed a patch-wise multitask learning BSc segmentation method to accurately detect BSc from scanning mammograms. And this this model was generalizable to cases without BSc deposition as well, unlike previous models, which only run for BSc cases only. We also demonstrated a strong correlation between BSc scores and adverse cardiac arrest over a period of 15 years. And this is it, and I would be happy to take questions.
Thank you so much, Aisha. So I would like to thank our speaker, Aisha, and I would like to ask the audience to give a virtual round of applause first before opening the floor to some questions. So first, like audience, do you have any questions for Aisha? So Aisha, I have a question. So you talked about you had a model MTL and another model regular. Like, how are those two models different?
Okay, yeah. I should have explained. So these are two versions of our model where how we are formulating the patch prediction task. We could formulate it as a classification task where considering the patch position as one of the fixed number of classes if the image size is fixed, or we could also consider it as a regression task where we want to regress the XY position like XY coordinates within the image.
Okay. And which model did you choose for your subsequent experiments, like the MTL model, I presume? Right?
Yeah, the best model. Yeah.
Uh, do we have any more questions? Okay. So if not, I would like to thank the speaker once more. And thank you so much, Aisha, for your presentation. And yeah, if anybody has any other questions and afterthought, please, Aisha can reach out to Aisha on her email. And yeah, that would be it. With that, I would like to ask the audience to again thank our speaker. And I would end the session.
Thank you so much for inviting me.
Thank you so much.
Okay.